Ozempic, also known as semaglutide, is a prescription medication primarily used to treat type 2 diabetes. Developed by Novo Nordisk and FDA approved in 2017, it belongs to a class of drugs that help lower blood sugar levels by acting like a hormone called glucagon-like peptide 1, or GLP-1, which plays a key role in regulating insulin production and appetite. Maybe you've heard the jingle, or maybe you've seen it on social media.
Weight loss.
Weight loss.
Easy weight loss.
Miracle diet drug.
Miracle weight loss drug.
And it's true, even though Ozempic's primary function is as a diabetes medication, it is also known to cause weight loss. However, it is marketed on the official Ozempic website that Ozempic is not for weight loss, but it may help you lose some weight. Given that approximately 90% of people with type 2 diabetes in the US are classified as obese or overweight, Ozempic can offer dual benefits by improving blood sugar control while also helping with weight management. However, there is a rising popularity of buying Ozempic solely as a weight loss drug. This can be a problem as there are severe side effects to using Ozempic, which include pancreas inflammation, vision changes, hypoglycemia, kidney failure, allergic reactions, and gallbladder complications. Furthermore, since Ozempic was created to be taken long-term for type 2 diabetes, short-term use solely for weight loss can cause weight to be gained back over time again. Given Ozempic's potential benefits for individuals with type 2 diabetes and its implications for weight management, it's important to understand how the body interacts with this medication. This brings us to the pharmacokinetics of Ozempic, which involves its absorption, distribution, metabolism, and excretion. By exploring these processes, we can gain a clearer picture of how Ozempic functions and the impact it may have on long-term weight management. Ozempic is administered as a subcutaneous injection, either in the thigh, abdomen, or upper arm, and surpasses first-pass metabolism. There is also an oral form of semaglutide, marketed as Ribelsus, although its bioavailability is significantly lower compared to subcutaneous administration, meaning the body absorbs less of the drug when taken orally. After subcutaneous injection, Ozempic reaches peak plasma concentrations in about 1 to 3 days. However, to fully achieve steady-state concentrations, where the amount of drug being absorbed is balanced by the amount being eliminated, this process takes about 4 to 5 weeks. The injection is highly bioavailable at around 89 to 94%, while the oral form only reaches about 0.4 to 1% bioavailability, showing the efficiency of the injectable form. GLP-1 is naturally degraded by a proteolytic enzyme called DPP4, and although it can degrade semaglutide, its structural modifications that we'll revisit in a few minutes make semaglutide more resistant to this degradation compared to natural GLP-1, and semaglutide also has a higher binding affinity to plasma proteins like albumin. As a result to binding with albumin, semaglutide has a relatively low volume of distribution of about 8 to 9.4 liters. This indicates that it stays mostly within the bloodstream. About 99% of this drug is bound to plasma proteins, which slows down its breakdown and prolongs its action in the body. The primary route of elimination is renal, with about 53% of the drug excreted in the urine, while a smaller portion, about 19%, is eliminated in the feces. But, as previously mentioned, the high affinity binding of semaglutide with albumin decreases its renal clearance. Overall, the drug has a long half-life of around 7 days or 168 hours, which supports its once-weekly dosing schedule. Several factors can influence the pharmacokinetics of Ozempic, such as age, weight, and clearance. Generally, older adults may experience changes in drug metabolism and excretion. However, Ozempic's pharmacokinetics are not significantly altered by age, meaning that typical dosing adjustments aren't necessarily required solely based on age. As for weight can affect the distribution and possibly the efficacy of Ozempic. Higher body weight may decrease the concentration of the drug in the bloodstream, potentially altering its effects slightly, but the clinical significance often remains minimal for standard doses. Ozempic's clearance is largely unaffected by renal impairment because it does not rely extensively on the kidneys for elimination. However, in patients with severe renal impairment, close monitoring is advised to ensure safety. Similarly, mild to moderate liver impairment does not significantly impact Ozempic's metabolism or clearance. Since data on severe liver impairment is limited, caution should be exercised, and these patients may require closer observation. This brings us to the pharmacodynamics of Ozempic, which involves its mechanism of action and therapeutic and toxic effects. As we've previously mentioned, GLP-1 is a hormone that has different actions aiming to reduce blood glucose and has effects on the central nervous system, which can reduce appetite and lead to weight loss. Semaglutide has a low molecular size with 94% similarity to the amino acid sequence of native human GLP-1 and 3 key modifications: the addition of a fatty diacid chain with a spacer sequence and 2 amino acid substitutions. So for the mechanism of action, semaglutide binds to the GLP-1 receptor on pancreatic beta cells, forming a receptor ligand complex. This binding stabilizes the GLP-1 receptor in an active conformation, allowing it to interact with intracellular signaling proteins. Once semaglutide is bound to the GLP-1 receptor, cyclic AMP, or CAMP, levels rise quickly. The increase in CAMP activates protein kinase A and other related pathways, which together enhance insulin release in response to glucose. The primary mechanism used by Ozempic to reduce levels of blood glucose is via increased insulin secretion and decreasing glucagon secretion. An increase in insulin secretion also contributes to suppressed hepatic gluconeogenesis and an increase in other effects of insulin, which all work together to reduce blood glucose levels. A delay in gastric emptying in the early postprandial phase also contributes to reducing blood glucose levels by reducing the amount of glucose entering circulation. As mentioned previously, GLP-1 receptors are found in the central nervous system in areas such as the arcuate nucleus, paraventricular nucleus, and subfornical organ. GLP-1 stimulates GLP-1 receptors on the vagus nerve and on the mentioned areas of the brain. Activation of these receptors leads to increased POMC/CART neuron firing and inhibition of NPY/AGRP neurons via GABA transmission. These combined mechanisms lead to an overall decrease in appetite and increase in satiety. As Ozempic is a GLP-1 receptor agonist, it takes advantage of these pathways, which leads to a decrease in the patient's weight as a result of a decrease in the patient's appetite. Although Ozempic has some beneficial physiological effects that can improve patient health, it also has some toxic side effects. Since Ozempic is less prone to proteolytic cleavage, it has increased half-life as compared to GLP-1. This increase in half-life contributes to some gastrointestinal symptoms patients may experience, such as nausea, vomiting, and diarrhea. Other toxic side effects that are not as common include increased pancreatic enzymes, acute pancreatitis, gallstones, gallbladder inflammation, and increased heart rate. There is also a risk of hypoglycemia if Ozempic is used with other drugs such as insulin analogs. Now let's talk about the implications and future outlook of Ozempic. On a population level, Ozempic's role in managing type 2 diabetes has been transformative, improving blood sugar control and reducing serious complications like kidney failure, nerve damage, and vision loss. These improvements contribute to a better quality of life for many. In recent years, Ozempic has also become an ally in addressing the obesity epidemic, with some using it off-label for weight loss. By helping reduce obesity rates, Ozempic may indirectly decrease chronic diseases like heart disease, stroke, certain cancers, even for non-diabetics. However, its popularity also raises societal questions. The shift towards pharmaceutical weight management has led some to reconsider traditional lifestyle changes such as diet and exercise, with an emphasis on medical intervention instead. Ozempic also has some environmental implications. Improper disposal of Ozempic pens or vials by throwing them out or flushing them down the toilet can introduce drug compounds into the environment.
This can contaminate
all the soil.
and water.
Pharmaceutical waste like this can affect ecosystems, potentially harming plant and animal life. Even garbage disposal can contribute to contamination, as Ozempic residue may enter waterways, disrupting aquatic ecosystems. However, Ozempic's high costs also raise concerns about health equity, since wealthier individuals are more likely to afford it, particularly for weight loss, while lower income patients who may need it for diabetes management face access barriers. This price disparity can deepen existing healthcare inequalities. And to add on to this point, there's also an accessibility gap globally. While Ozempic is more available in high-income countries with advanced healthcare systems, its access is limited in lower-income regions where diabetes rates are on the rise. This could increase the global burden of diabetes as some populations miss out on modern treatments. Another issue lies in the high demand for Ozempic as a weight loss aid over recent years, which has led to shortages affecting patients who need it for primary use managing type 2 diabetes. These shortages raise serious accessibility concerns, especially for individuals who rely on it to control their blood sugar and prevent complications. Although Ozempic shows cardiovascular benefits for people with diabetes, there are knowledge gaps in its long-term effects, especially for those using it primarily for weight loss. Most data comes from studies lasting up to 2 years, such as the SUSTAIN trials, but the effects beyond this time frame are still unknown. To address these challenges, several new policies, interventions, and technologies could be implemented. Regulatory guidelines, for instance, could prioritize access to Ozempic for people with diabetes and metabolic disorders, helping reduce shortages by limiting off-label use for weight loss. Expanded insurance coverage for weight loss treatments could also improve equity. Many insurance plans cover Ozempic for diabetes but not for weight loss, which limits access for individuals using it to address obesity. Ultimately, while Ozempic has made remarkable strides in revolutionizing the treatment of type 2 diabetes and obesity, there is still a long road ahead to fully understand its long-term impacts and optimize its use for diverse patient populations. Thank you for watching.